So the next speaker is Mr. Michael Canty. So Michael is a consultant paediatric and adult neurosurgeon based here in Glasgow. One of the things when you organise sessions like this, you get to see just how talented your colleagues are. So Michael has a pharmacology degree from Dublin, a master's in neuroscience from Edinburgh, and his medical degree from Oxford. He trained in neurosurgery in Scotland, in Dundee and in Glasgow, and he did a fellowship at the Sick Kids Hospital in Toronto. And in addition to his paediatric interest, he's also the adult surgical lead for the Scottish National Deep Brain Stimulation Service. So if you can join me in welcoming Mr. Michael Canty.
Thanks a lot, Chris, and thanks everybody who's here, and thanks to the organisers for having me, although I'll never forgive Chris for scheduling me after Alistair. That was a fabulous talk, Alistair, really enjoyed it. So my name is Michael. I'm one of the members of the Paediatric Neurosurgical team in Glasgow, and it's really great to see how many people are here and how intimidating this auditorium is. It's almost as intimidating as negotiating with a cardiothoracic surgeon about whose case needs to go next, but not quite. So I'm going to talk a little bit about head injury in children, and a little bit like Alistair, I'm going to be slightly self-deprecating and focus on some of the non-immediately surgical aspects of this. So a little bit about what I think the role of a surgeon is in dealing with pediatric head injury, a little bit about decision-making, and some of the special cases that mark out children as being different from adults in the management of injury. So very briefly, a little bit of epidemiology. About a third to half of all traumatic brain injury, these are UK figures, they're a little bit out of date, but about half of all head injury that's seen in an emergency department is pediatric. And most of that happens in the summertime and happens in the afternoon and the evening, as you can imagine. Like adults, the males predominate, and the under threes comprise almost a third of children that are admitted to hospital. And especially relevant in Glasgow, we see a higher risk of that with increasing poverty and increasing social deprivation. I'm always hesitant now to label any sort of head injury as minor, but the majority have a more minor head injury, so typically a kind of injury that isn't imaged or doesn't require admission to hospital. And about 1 in 10 will have a fracture to their skull or have a visible injury to their brain seen on imaging, so some bleeding or bruising inside the brain. The majority happens due to falls at home, and that's mainly the kind of toddlers. And in older kids, we see that more usually due to sports injuries. As to these UK figures, that was mainly rugby, quite a bit of football, horse riding injuries strike fear into me, hockey and trampolining. And these are very jurisdiction dependent, obviously, and this list doesn't comprise e-scooters, which is another thing which terrifies most of us involved in head injury these days. And also it depends on which country you live in, and Alistair's alluded to some of the problems that's seen in the global south. When I worked in Canada, we saw a lot of injuries from quad bikes, all-terrain vehicles, and ice hockey. My main learning point was don't play ice hockey. We do see assault and abuse as well, unfortunately, in children, and we see that in less than 1 in 20, thankfully. I'll touch a little bit on that later, and I know some of my colleagues from the Children's Hospital are talking about that this afternoon as well. The highest risk of injury is if you're a cyclist or an e-scooterist and you're hit by a car, and most of the serious injuries that we see are either pedestrians or cyclists, e-scooters, hit by cars, unfortunately. As I say, it changes over time, so trampolining is on that list. Just talk to anyone who works in a children's hospital about trampolines, and the same is true for e-scooters, and literally just looking at these pictures generates this kind of reaction in anybody who works in pediatrics. So this is the sort of view that neurosurgeons have of themselves. They may try to pretend that's not the case, but it is. We sort of think we dress very kind of dapper and stylish. We trying to stare off into the middle distance with a 1,000-yard stare, thinking about things mystical and cryptic that no mere mortal could understand, and also devilishly handsome. And sadly, the truth is far more prosaic than that. And these sort of things, again, as alluded to previously, are far, far more important than we'll ever be. So the figure in the middle at the top there, at least, is a neurosurgeon. So that's Hugh Cairns, a sort of real giant of British neurosurgery. the first person to set up a hospital or unit or institution specifically for looking after head injuries in the aftermath of the war. He was also so kind of taken by the death of T.E. Lawrence of Arabia, in a motorcycling accident, that he again is probably the person most solely responsible for the advent of motorcycle helmets and prevention of a huge amount of death and disability in motorcyclists and dispatch riders. On the bottom left there is Niels Bolin. That's a Swedish engineer who worked for Volvo eventually, and that's the man mainly responsible for the advent of seatbelts. So he studied a huge amount of road traffic accidents in Sweden and discovered that in both belted and unbelted occupants. So if you didn't have a seatbelt on, you died across a whole range of mechanisms and speeds. If you wore a seatbelt, if you were going under the speed of 60 or your passenger compartment remained intact, you generally survived. And it's thought roughly that he's responsible, or seatbelts rather, are responsible for probably saving close to 300,000 lives in the US alone since the 70s. So all of these kind of public health interventions will do far more than we can for head injury. And again, thinking about Glasgow specifically, we've seen a similar sort of improvement when we think about looking at violence and interpersonal violence as a public health problem rather than as a specific clinical problem. Nonetheless, we do have our role to play, and that really is the assessment and management of the more severe end of head injury, identifying and treating life-threatening injury. And there's also the surgery bit, and that's in many ways the least important or the easiest, certainly the easiest to make decisions about, I think. We also have a role in the application and interpretation of specialist monitoring, and by that I really mean intracranial pressure monitoring. I'll talk about that a little bit in a second. And as I say, decision-making, and that might be decision-making about who to operate on. That's usually relatively straightforward. Who to scan, who to admit, who to monitor, and sometimes more difficult decisions like what kind of injuries are unsalvageable. So just a little bit about the surgery, but I'm deliberately not kind of concentrating on that. So this is a young man who's been shot, and thankfully in the UK we see this really, really infrequently. And I'm very happy that this is not something I have a lot of experience with. And obviously our colleagues in other jurisdictions in the world see this far more frequently, almost on a daily basis. But this is a young man who's been shot in the forehead with a low velocity round. And you can see at the back of to the right of the picture there, the artifact from the round, which is lodged inside the back of his skull. And as I say, thankfully we don't have to deal with these sort of injuries very often, and they're very challenging injuries to deal with. And this is the sort of injury that gives you, as Alistair said, a huge primary injury, an injury you can do nothing about. All of that energy from that projectile has dissipated itself into the brain and caused really, really severe injuries that a neurosurgeon is never going to be able to tackle. These sort of injuries are a little bit more commonplace and a little bit easier to deal with. So on the left of the screen is a fairly typical extradural hematoma, so bleeding that happens outside the layer of the brain, inside the skull. And that's typically from a lacerated artery, usually as a result of a skull fracture. And these are sort of funny twins, these kind of injuries. So they're immediately life-threatening. That bleeding is arterial. It builds up very quickly and causes a lot of raised pressure inside the head and can be very, very quickly life-threatening. But the brain itself is relatively uninjured because these typically happen from a fairly low-energy sort of injury, a cricket ball to the back of the head, for example. And if that hematoma is evacuated in a timely fashion, patients do really, really well. And we see that kind of injury a lot more commonly in children than we do in adults. In adults, the layer of the brain tends to be a lot more tightly opposed to the inside of the skull, and these injuries are a little bit less common. On the right-hand side is a subdural hematoma. So that's a more extensive injury where the bleeding has happened underneath that layer that covers the brain on the brain surface itself. And you can see it covers a much wider area. And those injuries are typically more serious in the sense that the brain itself is usually injured too. There are higher energy that's gone through the head, dissipating itself into the brain. And although we evacuate the hematoma to reduce the mass effect and the pressure inside the brain itself will also be injured. And everything that we're doing after that is trying to deal with the aftermath and the consequences of that initial injury. I wanted to talk a little bit about intracranial pressure monitoring, partly because it's a little bit niche, and I quite like it, but partly because it's one of the things that's quite useful in pediatrics, and we do quite a lot of it in pediatrics. A bit like, again, what Alistair said about all of those trials in head injury, and the head injury literature is full of evidence of things not being helpful, which is really depressing when you work in it. And ICP monitoring is unfortunately the same. There's some minor or poor quality evidence that it's maybe helpful if you look at it over a lot of people, but it's definitely not unequivocal. But we do still, we think, find it useful. So this is where we're inserting a probe into the brain, about 2 centimeters sitting inside the surface of the brain, and that's directly measuring the pressure inside and giving us an idea about goal-directed therapy, so allowing us to calculate some values about that particular patient's physiology that might allow us to tailor their treatment to them, and also as an early warning system, so telling us that there's a problem developing before the patient shows signs of that, so allowing us to act a little bit sooner, a little bit quicker to diagnose it and to treat it. It also allows us to calculate some other useful values, and I've picked one, cerebral perfusion pressure, and that's basically the pressure that your brain needs in order to maintain its blood flow. And you need to know what the intracranial pressure is to calculate that accurately. So knowing that, again, maybe helps us to tailor treatment rather than just following a guideline that's developed for hundreds of thousands of people, adults and children. It maybe helps us to tailor it more specifically, more bespoke to that individual who's in front of us. There's some emerging advances in that, which I'll come on to in a second, but at its most basic, this is a treatment, which is used to trigger therapies and trigger investigations. So this is ICP monitoring at its most basic, and this is what we would be used to seeing probably over the course of my career so far. This is mostly what ICP is used for. So where you see this patient monitor above the bed, you've got a invasive blood pressure at the top from an arterial line, you've got a non-invasive blood pressure from a cuff in the center, and then in the pink, the number there that says 28 with the trace next to it is the intracranial pressure, and that would be quite a high intracranial pressure. So that basically just gives you a number that tells you what the pressure is. And that's useful, but that useful is definitely limited, and we don't know what an individual person's intracranial pressure should be moment to moment. We think we do, but we only really have a very vague sense of that. And this is sort of where intracranial pressure monitoring is starting to evolve to. So this is a computer program that's giving the same information, it's giving the pressure, it's measuring it on a sort of second-to-second basis, but it's also comparing it to all of the other physiological parameters that are inputted into it. So the patient's blood pressure, their CO2, their heart rate. And I'm not going to go through it in detail, but basically what it's showing is it's giving us the pressure that we require to drive blood into our brain at the top. That's the kind of yellow bar that looks like a kind of Himalayan mountain range. And then it's also giving us some reactivity. So it's seeing what's happening to the pressure inside the patient's injured brain when their blood pressure changes. So in all of us here, our brain is amazing at maintaining the same flow into our brain no matter what our blood pressure is within reason, and does that across a whole range of blood pressures, and we call that autoregulation. And in the injured brain, we see that ability of the brain to do that be lost. So where in the injured brain, if we get a big rise in blood pressure, we can get big rises in intracranial pressure, and that's really harmful. So this software is basically measuring that for us and giving us a sense of whether that ability of the brain to regulate its blood flow is present or lost, or how impaired it is. And it's also giving us that little curve you see, third from the bottom, is giving us some specific targets to aim at. And again, this is trying to tailor the treatment specifically to the child in front of us, rather than relying on a generic guideline for adults and children generated across thousands of people. So in general, in neurosurgery, we respond to sustained raises in intracranial pressure. All of us will get a rise in intracranial pressure in this room if we cough or sneeze or laugh, but hopefully that will last for just a split second. But in injured patients, we're responding when that pressure rises and doesn't go down. And that's more challenging in the very young, partly because we're still not 100% sure what their pressure should be, partly because monitoring pressure is much more difficult in the very young. And in fact, it's unusual or rare or perhaps even unheard of to monitor intracranial pressure in the under 1-year-olds, partly due to that rigid box concept, again, that Alistair mentioned. But it does give us a lot of information. It's too soon to know whether all of these fancy software, machine learning algorithms, and dare I say artificial intelligence approaches are going to lead to an improvement in outcome. But I think in general in head injury, it's little marginal gains that we look for that maybe we'll see an improvement, but it will take probably some years for us to know whether that's the case or not. So lastly, I was going to talk about a couple of special cases in children in pediatric head injury specifically. One is non-accidental injury, and one is decompressive craniectomy. And hopefully that leads on really nicely to Alistair talking about that in the adults. So non-accidental injury, I know Lindsay's going to talk about this afternoon. So we see a whole range of things, or often a spectrum of non-accidental injury. We don't see it that commonly, thankfully, but we do see it regularly. And that can just be a skull fracture. It can be bleeding underneath the layer of the protective layer of the brain, a subdural hematoma. We see bleeding at the back of the eyes, so retinal hemorrhage. And then when you go looking for it, you can sometimes find older injuries, like old healing bone fractures or unexplained injuries. And occasionally, these can be life-threatening or life-changing injuries. So this is an example of an MRI scan. And the picture on the left is showing you subdural hematomas, so it's those grayish layers at the outside of the brain, and those are non-new, so those are older injuries, a few days or a few weeks old, for which there isn't a good explanation, and those are always suspicious in children who are a few months of age. But MRI gives us lots more information, and the picture on the other side is an MRI technique that gives us a bit of information about whether the brain is injured, and specifically whether it's injured due to a loss or a reduction in blood supply. And it's maybe a little bit hard to appreciate, but there's some areas around the brain, around the sort of orbit of the brain that are brighter, that are whiter, and those are areas of the brain where the blood supply has been impaired, and those areas of the brain are injured. So this is actually a very significantly injured brain as a result of injury that's been inflicted intentionally. So I think within pediatric neurosurgery, non-accidental injury is one of the most challenging areas. It certainly is for me. It's got lots of social and legal aspects, as you can imagine, and that can stretch clinicians. So in neurosurgery, we're relatively relaxed about dealing with the clinical side of things. We can look after the children's head injuries. They rarely need surgery, thankfully, but when they do, we can manage that. But it's more the overlying social and legal aspect of things that we find difficult, and obviously that becomes very involved. At its best, it's emotionally taxing, and at its worst, it's extremely distressing. And it's really important that we have the whole interdisciplinary team approach to that we usually do in the hospital that incorporates neurology, rehabilitation, social work, our colleagues in speech and language therapy and physio, and obviously the police as well. So non-accidental injury, not really some. We see lots of non-accidental injury in adults too, in terms of interpersonal trauma. But in children, it's a very difficult area. And lastly, I wanted to talk about decompressive craniectomy. And Alistair's given a really nice description of that. I'm going to give a much less scientific description. This is the original Hail Mary pass. This is from the 1970s. The Dallas Cowboys were playing the Minnesota Vikings. And the Hail Mary pass is the last ditch. You've got no other options left. Just throw the ball as far as you can to the far end of the field. I'm really sorry for using an American football reference. But decompressive craniectomy is the Hail Mary pass of neurosurgery. It's the last ditch maneuver to reduce intracranial pressure that would otherwise be imminently fatal. And as we can see, it involves removing a large area of the skull in order to allow brain swelling and essentially to save life. But it's a very it's an operation that's very morbid, and I mean morbid in the susceptible to complication sense rather than the Edgar Allan Poe sense. But it's got a very high complication rate, and my very talented colleague, Mr. Laraway, is going to talk about that after me, I think, because it requires reconstitution of the skull at a later date, cranioplasty, either with your own bone if that's been stored, or with an artificial piece of bone. And in adults, whether to carry this out is a difficult, nuanced decision, again, as we've heard. We know that it can be life-saving, but it does come at great cost, and the problem being you don't know what that cost is to the patient who's in front of you. You only really know statistically what that cost might likely to be. You might be making this kind of decision in the middle of the night at very short notice with very fraught relatives trying to understand what would be best for that particular patient, what would they have wanted. And in children, that's a little bit different. So first of all, their brains are far more plastic than ours are. And they can make recoveries that would be unheard of, really extraordinary in the adult setting. So injuries that we see that we think are going to be fatal or utterly catastrophic and life-changing, I think all of us who work in pediatrics will have the story of the child that's made, no other way to describe it than a miraculous recovery. And so it's the hope that kills you. And so that kind of plasticity of children's brains means that we have a much lower threshold for doing aggressive life-saving surgery like this in pediatrics, because some of those children go on to make extraordinary recoveries. Prognosis in brain injury is notoriously difficult anyway, and in children it's particularly difficult. With all but the most severe injuries, all bets are off. It's very, very difficult to say how an individual child is going to do with any sort of given injury. I don't really need to talk about rehabilitation because we had a whole morning of it, and the fact it was first is brilliant. That really tells you how important it is. And it's become a bit of a cliche to have the importance of rehabilitation slide in a surgical head injury talk, and that's really good because it didn't used to be a cliche. And now it means that we all recognize how essential this is. And it's good that we're recognizing that, but it's still significantly under-resourced compared to the scale of the problem and compared to its importance within the whole pathway of looking after head injury. So that includes all of those things that I've written down there: physiotherapy, OT, speech and language therapy, psychology, neuropsychology, outreach, schools, third sector, sport. I need to add spiritual rehabilitation to that. I was really taken by Giles Yates' talk about that. I thought that was really good. And I think I would summarize this as saying what we're trying to do when we've done the cool bit, with all of the fancy software and the operation. This is the really difficult and really important bit where our colleagues are trying to maximize the potential of that child's brain that's recovering. And that cannot be understated how important that is. So that's all I was going to talk about. Thanks very much for listening. I cannot miss an opportunity to embarrass my colleagues, some of whom are sitting in the crowd. But this is the Paediatric Neurosurgical team in Glasgow, but they're a really, really fab group of professionals who do an amazing job looking after some of Scotland's youngest and most vulnerable patients. It's a pleasure to work with them.
Thank you, Michael, for a really engaging and complimentary talk to Alistair's.